I see your slides.
Good. I'm going to so thank you for that lovely introduction, Amr. I am in the middle of a mid-career move. I'll be at the Medical College of Georgia at Augusta University in about a month. The discordance between my slide title and Amr's introduction. I can't talk, nor can anyone else talk about success in the printing or fabrication of respirators. Even though there's been a lot in the news about it, it's actually succeeded in bringing a respirator de novo into a hospital. We have had success with the fabrication of masks and textile respirators. So I'm going to talk about what one needs to do to get a fabrication lab ready for the next time that we need to do emergency fabrication. Thus, lessons learned. So, rapid prototyping in a fabrication lab is an iterative process. And the advantage of modern fabrication techniques is that they're augmented with computers. In the past, any new part had to be meticulously planned in a machine shop and worked on for days and days to create a template and then create the machines that could fabricate the part by routing and injection molding and so on. Now we get to a prototype much quicker. We can either sample using some sort of scanning technique, a real world object to use for our computer file, or we can design one de novo on a computer aided diagnosis or computer aided design program, a CAD program. The files that we create are called stereolithography files after the first computer-aided additive fabrication technique, stereolithography, but it's used for all the techniques. Once you have that created, you fabricate something. That's the mid-step. And then the step that really stopped everyone in their tracks for the COVID pandemic was the fact that you need testing for medical equipment. And no one was ready to do that. No lab like mine anywhere had ready access to testing facilities. And I think that more than anything else was our pigeonhole. So just to circle back for a moment to fabrication techniques, what most people think about and what's been reported in the news are the computer-aided techniques, the additive techniques, where you use light beams to fuse and solidify resin, or you use extrusion device to extrude a plastic that's hot and malleable and then hardens, or sintering, where you change a powder with a laser or an oven into a solid. And then there are also subtractive techniques. CNC machining is what it's called, but that's from the, I guess, the 80s, computer numerical control, and that's where lasers or routers are used to control machinery that cut away things. All of this grows out of traditional fabrication techniques that are used in fine art, and that's why our lab at the University of Kentucky intentionally is in the School of Art and Visual Studies. So coming back to testing, if you're going to fabricate anything that has to do with medicine, you're going to need collaborators from other university labs, such as textiles, garmentry, art, material science. Hello? Oh, okay. And also, you need access to the people at your own medical center who do testing. So one issue I'm having right now is that the folks who do the saccharin test for fitting of masks, that's one of the steps after an inhalation and exhalation test you can do yourself. You have to do a small molecule test. And when I ask them if I can use their equipment because they're people within the regulatory workflow, the first thing they say is no. And why? You can't do that. The answer is always no. So that's also something that needs to get sorted out ahead of time. So at this point, I'm going to switch to, can you guys see my screen still? Our website where we have video, and we'll do the rest of this with video. And anyone who wants to can later go to YouTube and just look up SNAV's Volumetric Visualization Laboratory and get to the same set of videos. So the first thing I talked about was having equipment that can sample reality to create files. And we have I'm going to have to mute this, a video that we made just about this near the beginning of the epidemic, where we used a medical CT scanner as a object scanner. There are machines you can buy, CT machines that are specific to industry, but we don't all have those lying around or money for them. But you can, if you have a recent generation CT scanner, hack it to make it equivalent to one of the scanners that they use for parts. And this video,
we're still seeing your PowerPoint with the last slide titled testing.
Okay, give me a sec here. Windows, oops. Just go web meetings. What I need is to, here, share web browser. And what do you see now?
We see another screen that you can now browse the web.
Okay.
And share your web. Yeah.
Can you see a video going now?
Yeah.
Okay. So this, just coming back here, let me just back this up for a minute. This is the YouTube channel so that people can go and watch these at their own pace later. We have a video showing how to use a CT scanner to scan objects. And once you scan an object, you then have to have some sort of software, post-processing software, to then change your CT data to an STL file. This video walks through how to do that in Terra Recon's Aquarius Intuition. This company's changed its name now. It's called Intuition AI. There are other ones. There's AW by GE. There's Vitria by the Canon Medical Group, etc. So you have to have personnel who know how to use this. And then here, if I skip to the end, we were using a whiskey glass here as an example. There's the glass and there's a print of it. So that's one type of sampling equipment. Another example would be, here we have structured light scanning. here. And this is a local company that was started by our Department of Engineering that is using bands of light cast on my colleague Dr. Lau's face here to create, excuse me for a sec, I had to stifle a sneeze, to create a 3D model of his face. And then just to demonstrate how you can put data from a scan together with a rendering. You know, here is a scan of my face and a customized gasket specific to my face merged with computer-aided design component, which is the muzzle of the respirator, that's the part beyond the seal, and a canister, excuse me, and the cartridge for filtration. So those are all parts that you need. Just to show one other example of how good a CT scanner can be at scanning parts. This is a 3M full face respirator, and it looks like a very detailed schematic, I mean, detailed computer rendering of a mask. This is simply a CT scan where we've utilized our advanced visualization tools to segment out the important portions and render them in pseudo-color. So then on to fabrication. A lot of people have labs where they'll print, occasional anatomic models, something like this, but without a proper dedicated workshop, you're not going to get very far, because if you're trying to fabricate something that's going to really interact with a human being, you have to have a place where you can really. How am I doing on time?
Yes, you still have 2 minutes.
Okay. All right. So here's sort of a workshop working on a gasket, but you can see we have good ventilation. And then another thing that we need in this whole process that we didn't have initially is you need biocompatible resins. So we had to test a number of resins and go to a number of different vendors before. This gray resin here is completely hypoallergenic and durable and does not off-gas anything noxious. A lot of resins, just like new furniture or a new car, off-gases fumes that aren't good for you. That new car smell is actually a formaldehyde smell. So we had to get that. And then the final step is fit testing to make sure that whatever device you create actually works. So we want to be ready for the next big medical calamity, the next pandemic, whatever comes our way as a medical fabrication lab. And we at Kentucky have almost all the parts, and we're at the point now where we have working prototypes of respirators, but we're still getting all the pieces together. So when you guys go back to talk to your deans or your CEOs about fabrication, you can't just say, I want to buy a high-end printer. There's so many other things that you need to think about. One is, how are you going to get the data to print? Again, I'm just reiterating, that's the scanning equipment. The next is the workspace. And then the final thing is testing labs and collaboration. The printer itself is only a small part of the whole process and what you need. Do I have a minute to take a couple questions?
So just a question, very quick question. For Tanta University, what do they need to do or to have so they can print this protective equipment? In short.
Sure. Okay. So you need, now, is it just a medical university, Tanta University, or do they have engineering, etc.?
They have almost everything, all kind of specialities.
Right.
Yes.
So
Yes.
the first thing that needs to happen is you need to take stock of the resources in all the other colleges besides the College of Medicine, so there's no redundancy. Then you need to find a shop where the stuff can live. Space in the hospital is at a premium. Really, a lab shouldn't be within the hospital physical plant. It should be somewhere close. Once you've identified that, you should identify all the fabrication devices that are already on campus and the people who have expertise for that. Then you have to go to imaging or surgery and see, who are the people that you have who can bridge clinical to printing. You need people who understand the process as well as the problem. Those two things have to come together. Here's my colleague in art, and he doesn't understand the problem. We had to teach him that, but and I understand the problem. And then we have students together who understand both. So that has to happen. Then if you don't have printers already on campus, then you have to think about a budget for them. And then lastly, you need the most important thing is you need to have an emergency fabrication plan and workflow and an organization chart. Those are the things that we lacked. We have them now. We have our assistant vice president for technology is also now designated as the vice president for fabrication. So we now have a workflow within the university and also within the Commonwealth of Kentucky, by the way, for how these things go. And that may be the part that took the most time, is having that organization. So I would say organizing yourself, having a plan, having a hierarchy, that's the most important thing. And then the second most important would be to fill in any gaps in equipment that you might have. I imagine at a large university, there will be no gaps. The only gap might be the biocompatible resins. Long-winded answer.
That's fantastic. I really appreciate your help with that, and we might have another talk with Dr. Kamal Okasha about this to see the feasibility of this, and with also Dr. Tarek Diasti, because this might be very helpful, not only for Tanta University, but also for all Egyptian universities. Thanks, Mike.
Thank you, Professor Amr and Professor Michael, for this elegant presentation. And we may have the opportunity just to meet Professor Michael and just make a kind of connection with him for the sake of many universities in Egypt to implement this 3D personal protective equipment. And in actual fact, we have with us Professor Mohammed Al-Nimr. He's a biomedical engineer and IT engineer for our university, and he will just be with you in a second to comment and just to see the possibility of implementation in Egypt. Professor Mohammed Al-Nimr.
Hello, everybody. My name is Mohammed Al-Nimr from Tanzania University, Faculty of Engineering. Basically, I am electrical engineer, associate professor. We have tried to create our own solutions for not mainly medical devices, but something for cleaning up and assisting the medical staff to avoid infection, different perspectives. We have developed in Tanzania University some let's say, low-cost devices and other types of high-cost devices for cleaning units or I don't remember actually the medical expression, but it's a unit for entrance at the gate or at the entrance to clean up visitors to the hostels of طنطا University. We have one basic construction type. It's very simple. It can be used for all the environmental perspectives here, like low cost and low requirement. Another one, a little more sophisticated actually. It has ultraviolet, hand cleaning, camera, temperature sensing for entrance as well. Another perspective is ventilators. Faculty of Engineering has constructed some research team devoted to create some ventilators, like low-cost ventilators, in fact, to assist in case of high demand of ventilators is required. However, it seems after like 2-3 months already, ventilators doesn't show a real shortage in the current situation in Egypt, at least.
Professor Nemr. Professor Nemr,
Yes.
thank you very much for your comment. I think it is a good opportunity to collaborate with the University of Kentucky through Professor Winkler and Professor Amr. And I think it is a good chance to contact them after this webinar to start to think how to collaborate with this very excellent and smart ideas. Thank you very much. Professor Amr, I think Professor Amr, hi. Professor Amr will introduce the next speaker, please, Amr.
Thank you so much. Thanks, Mike, for this excellent presentation. The next speaker is my friend from University of Kentucky, Javier Nera. Is really one of the multitask person, very smart. He's a physician scientist. He does both critical care nephrology, and he does a lot of research in the AKI era. He is very well distinguished, very good speaker. Without further ado, I will let him to talk about AKI and the COVID-19 pandemic lesson that we have learned.
Thank you, Amr, for the invitation and everybody present in this forum. I'm going to talk a little bit about acute kidney injury. I'm going to start sharing some slides. You let me know. Is it you guys are able to see it?
Looks very good.
Excellent. Okay. So it's a brief presentation, and let me see if this can go. Yep. So we're going to talk first about COVID-19 and AKI, some concepts about pathogenesis, what we have learned this far. Then we're going to talk about some epidemiological studies that have been recently published, and a little bit of concepts about renal replacement therapy for patients with acute kidney injury. As we know, or have been understanding the pathobiology of COVID-19, we have the time course in the x-axis. Everything starts with the viral response phase. At this stage, most of the time we have symptoms like dry cough, diarrhea, headaches. Patients sometimes are ambulatory. But this can evolve into a stage 2 or pulmonary phase, in which we have a shortness of breath. Some of these patients will develop hypoxia. And this is when we have pneumonia, abnormal chest x-rays, low normal procalcitonin, transaminitis, and these patients, some of them may require hospitalization. Importantly, there is then a host inflammatory response phase that in some patients, it's progresses to a hyperinflammation stage where we see complications like ARDS, shock, cardiac failure. At this stage, there is elevation in inflammatory markers, most commonly CRP, LDH, IL-6, D-dimer, and of course, the mortality in these patients is very high. As you can see in the bottom of the slide, there are several therapies that are being tested. Some of them we have evolving data, but as of now, there is no standard of care for treatment of COVID-19. Takes a little bit to pass the slides. Let me see. So it's going now. Of course, acute kidney injury will start to occur in this stage 3 hyperinflammatory stage or phase of COVID-19. Okay, it's a little bit slow, but let's try to keep going. So here you can have, in terms of acute kidney injury, pathogenesis is very variable. We can have possible mechanisms that affect the kidney, hypovolemia, particularly in the viral stage, in the early stage of the disease. Some of these patients are very exposed to fluid loss and can become hypovolemic. This can stress the kidney. Some of these patients will develop ATN, and this is more in the inflammatory phase of the disease, cytokine storms, high levels of these molecules, injury pattern molecules of lung injury. We can have also respiratory failure, and the crosstalk between the lung and the kidney can stress the kidney further. Some of these patients will develop rhabdomyolysis as well. Importantly, there is a hypercoagulable state in these patients that can have some TMA manifestations, and this vascular glomerular involvement can significantly affect the kidney. We can have also states of low perfusion or venous congestion, and this is related to fluid overload and the decreased ejection fraction in patients that develop cardiogenic shock. Importantly, when these patients develop fluid overload that is significant, right ventricular failure, it's also a key factor, especially in patients requiring high PEEP and that are already positive in terms of fluid balance. And certainly there is some insights about direct viral infection of the renal epithelium. We know that the renal epithelium expresses ACE2 receptors, and therefore there is an entry for the virus to the kidney. Why the slides take a little bit long to, probably it's too heavy. Okay, so now the pathogenesis, as you can see here, this is a recent study from the New Orleans group here in the United States. They tried to classify etiology of AKI based on urine microscopy and some of the clinical characteristics of the patients. Most of the patients that developed AKI in this study had ischemic ATI, so acute tubular injury, most of the time related to hypotension or changes in blood pressure, arrhythmias, and severe volume depletion. Some of the patients were categorized as having toxic ATI related to rhabdo or any other toxic agent identified. And there were some combined cases of ischemic and toxic, but less. And there are some patients that there was some positive clinical signs of glomerular lesions or acute interstitial nephritis. But as you can see here, most of the injury signature is related to ischemic ATI, toxic ATI, and manifested as ATN. Now, as you can see in this slide, some of the concepts in terms of pathogenesis, just to summarize this initial part of the talk, is that angiotensin converting enzyme 2 receptors are expressed in kidneys, and this has been demonstrated in humans. Some studies have recovered viral RNA in the urine, but others have not. So we don't know still if this could be helpful for guiding treatment or diagnosis, the detection of viral RNA in the urine. Viral particles are expressed in the brush border of the proximal tubular cells, and to a lesser extent expressed in podocytes, that where there are some anecdotal cases of glomerular involvement. Definitely microthrombosis is present in the kidneys, and you can see in the biopsies TMA. Proteinuria hematuria has been described not uncommonly, but nephrotic range proteinuria is atypical. Now, as you can see here, this is a nice diagram recently published in JSON that just summarizes what we discussed in the prior slides. So the virus can enter the renal epithelium or renal epithelial cells through the ACE2 receptors. And then here you have a milieu of different pathways that can predispose to kidney injury: angiotensin II activation with complement activation, and also reduce angiotensin 1-7, the cytokine storm, and this will generate this status of hypercoagulation and microangiopathy. At the same time, the direct viral invasion in the kidney can produce this tubular epithelial and podocyte damage, and the rhabdo itself, can damage the tubular epithelium. And all these can predispose the kidney to ATN or interstitial inflammation, that are the common manifestations that we have found. In some cases, some signs of TMA and microangiopathy as well. This same pathophysiology will occur in other organs, but in this particular case, when the other organs are also injured, there is a crosstalk that we have in the last few years identified to be very important for organ injury and also for organ recovery. So unfortunately, in this disease, there is systemic involvement of multiple organs. Seems like when the slides had some figures, takes a little bit of to pass them. Okay. So this is a nice also diagram just to summarize that this cytokine damage, or release syndrome could affect the kidney and also organ crosstalk, cardiorenal, and the involvement of the lungs. And of course, the systemic effects of fluid overload, rhabdo, and endothelial damage we should also consider. It's important because there are some modalities of extracorporeal support that can have some impact on cytokine removal that are being studied. And I think you will see more of this data coming in the next few months about the impact on this, not only in cytokine removal, but on patient-centered outcomes, which is important. Okay, so in the next part of the talk, I'm going to describe a little bit of the epidemiology of AKI in studies that have been published. This is before COVID. You already know that in the ICU, AKI is very frequent, 57.3% in this AKI EPI study. A lot of these patients, at least 1/3, develop severe AKI, as you can see, stage 2 and 3 AKI. The incidence of AKI requiring renal replacement therapy was in heterogeneous ICU populations is around 13 to 15% in what has been described. This is, of course, before COVID. We know AKI associates with higher mortality risk and other organ complications. Now, during COVID, there is at least 6 to 10% of cases that require ICU admission. When the patient reached the ICU state, at least we have incidence of AKI that has been described between 40 and 60%. And of those patients, 20 to 30% require renal replacement therapy, which is higher than the overall ICU population, which is concerning. And of course, have stressed a little bit the systems in terms of RRT preparedness and the logistics to provide RRT in the ICU. Okay, so some concepts that are important is that AKI is common in hospitalized patients with COVID-19. Here we're going to have a little bit of delay. I can see. Let me see if I can. Okay, so the incidence of AKI is estimated around 15 to 25%, but overall hospitalized patients, this goes up to 40, 60% in the ICU using KDIGO definition. As we discussed, of course, at least 30% of these patients will require RRT, which is a little bit of a concern for the capacity of RRT in the ICU. If I turn my video off, this can go a little bit faster. You guys have been having this problem. Okay. So importantly, though, patients that develop acute kidney injury requiring RRT, they have been described. Of course, there is no very comprehensive data yet, but the recovery rates, if they survive the ICU stay, are high. Most of the common indications for RRT are fluid management in these patients. This is an interesting study from the group in Sinai, New York, that reflect that, of course, if you see the stages of AKI by severity here, in purple color is and gray color are the patients with the stage 3 or patients requiring RRT. You can see in the patients in the ICU, there is a significant incidence of severe AKI and requirement of RRT comparing to patients that are not in the ICU, that they have most of the time mild AKI. The other interesting observation is that perhaps the incidence is differentially notable in patients according to race in a study that I'm going to show in the next slide when we get there. The experience from New Orleans, where there's a significant population that is African American, had a higher incidence of AKI RRT in the ICU, one of the highest in the US, that is close to 60%, which was very notable in terms of there is any predisposition of patients that are Black to be at higher risk of AKI and its complications. So let's see. Okay, so this is the study I was referring to, and you can see here the 55% of the patients that develop AKI require renal replacement therapy. In these patients, the mortality is very high, 72%, comparing to the mortality in patients that develop AKI but did not require renal replacement therapy. So this is very notable. And of course, we know in patients in the hospital, overall 50% mortality was also higher in this study of New Orleans. And as you can notice here, about 70% of the population was African American. Now, there is another registry in the US.
Professor Javier?
Yes, go ahead.
Have 2 minutes. Okay.
Got it.
Javier, I have, everybody who are attending this is exciting to hear from you, your personal experience, and have a lot of questions because there is no consensus, as you know, and in Egypt might be things are different from United States. Can you please highlight the use of steroids in COVID-19 patient, early versus late intubation and mechanical ventilation? And the last question for me is, in Egypt, they use isolation hospital. So they usually treat the patients in a dedicated isolation hospital for COVID-19. What's your intake on that?
Yeah, so I think those are very good questions, and I'm gonna quickly just mention a few things about RRT. What are the considerations that we need to have in these patients? Of course, we need to limit the exposure of the nurses and they have available PPE. But also we need to be concerned about the circuit clotting. It's higher in these patients due to the hypercoagulable state. So we need to develop a very careful anticoagulation protocols. The experience in the US have shown that the use of regional citrate when we use CRRT is not alone is not enough, that we need to use combined systemic anticoagulation protocols with heparin in addition to citrate to be successful. Also, we need to be careful with the vascular access when we prone these patients that are subject to movement of the catheter and the tip against the wall. So those are things that I want to just to mention before we finish. And to answer your questions, Amer, so your first question was related to steroids. Yeah, in terms of treatment for COVID-19 patients in the ICU, there is definitely more data coming that the use of try to attenuate the inflammation early on with use of steroids, and also with the use of monoclonal antibodies like tocilizumab for trying to palliate this hyperinflammation state has been shown that perhaps has some impact in mortality. As well as the very prompt institution of systemic anticoagulation with heparin due to the prothrombotic state. So, of course, steroids in patients that are critically ill have a downside as well, but especially if you recognize a phenotype of a patient that is rapidly deteriorating, transferred to the ICU with multi-organ failure and hyperinflammatory condition, the early institution of steroids and perhaps monoclonal antibodies like tocilizumab or other therapies that are being investigated right now, like the use of cytopheretic devices to kind of remove activated leukocytes, or not to remove them, but deactivate them through some specific technology, are perhaps going to be more widely used. The challenge for us is going to be to identify which are those patients eligible for these therapies, and that we can safely institute protocols that include these drugs proactively.
Excuse me, what's your experience regarding the use of tocilizumab? Do you have an experience with this drug?
Yeah, so we have been starting to use it at the University of Kentucky, but because I'm part of this registry that it's in the US that is called Stop COVID, that when we check patients across the US in different centers that were exposed to tocilizumab versus the ones that were not, there was a significant difference in mortality. Of course, this is observational data. This is not a randomized controlled trial, so we need to take this data very careful. But there is some signals based on observational studies that the early provision of these drugs may have some impact in mortality. As we know, maybe not every patient in the ICU may benefit from it, but I think the challenge is that, right? Try to identify those phenotypes of patients that are prothrombotic, hyperinflammatory, that we should provide these treatments early on and hopefully improve their survival rate.
Do you see, is there any rule for plasma exchange or plasmapheresis, total plasma exchange?
I mean, that's a good question. So everything that can palliate or mitigate the inflammation will be good. The problem with plasma exchange is you don't have control on the removal of macromolecules, right? So you will remove inflammatory cytokines, but all at the same time you will remove proteins or nutrients that are essential for the patient. So it's difficult to say if plasma exchange will be the modality of choice to mitigate inflammation. There are other technologies that do not have these effects that could be detrimental, like a removal of antibiotics or removal of macromolecules, that you just deactivate the cells and give it back to the patient. So with some cytopheretic membranes. I think probably we're going to try to use more of these therapies in these patients. Plasma exchange will be probably not the modality of choice, but it does have some effect on inflammation for sure. But the problem is you cannot control the other things that you remove.
Do you support early or late dialysis and early or late intubation and mechanical ventilation?
That's a very good point. Let me see if I can do this quickly. I think if I put my computer,
what's your intake about the isolation hospital? Do we need to isolate COVID-19 positive patient in a dedicated hospital, or can be admitted to any hospital if we can follow the protocols?
Yeah, that's a very good question. So I'm going to address your two questions. So this is very important to me. As we know, not every patient with COVID-19 manifests the same. There is a common condition that is hypoxia in this patient. But there are perhaps two phenotypes in the lungs. One is the phenotype L that has been described, where there is dysregulation of the pulmonary perfusion. And there is also a phenotype where it's more related to what we see in ARDS. Importantly, in this phenotype that is more related to ARDS, fluid overload could be very, very detrimental for the patient organ failure and recovery. And I think if we recognize this phenotype of ARDS type, we should be very proactive to provide the patient renal replacement therapy if there is already oliguria patient has acute kidney injury and there are signs of worsening fluid overload. Different in the left panel, phenotype L, most of these patients are susceptible to hypovolemia. They are in the earliest stage, and as we see, a lot of these patients, one of the most common risk factors of AKI was hypovolemia and hypotension. So perhaps institution of early RRT at this stage should be guided by electrolyte acid-base abnormalities, not necessarily by fluid removal, like will be in the ARDS type picture. So I think that's very important to recognize. The other thing I think, like, and I'm going to put a slide. Of course, in this phenotype, remember that the high PEEP can predispose to AKI through intra-abdominal hypertension and decreased renal perfusion, as we recognize. Now, the other thing is this, right? So how we prepare for a search, and if you have, you need to kind of estimate your ability to provide RRT to patients that are in the hospital. The way we do it right now, we have cohorted units. A cohorted unit, it means like it's a unit in the ICU dedicated only for patients with COVID-19 positive or are under investigation that are critically ill. So every dialysis we provide to these patients is at the bedside. And we have kind of a structure, a stepwise approach, depending on the total number of patients that need kidney replacement therapy in the ICU. The plan A is conventional operations. Plan B is when you have a system that have multiple hospitals that you can rotate machines between the hospitals according to the need. And then we start combining some modalities of renal replacement therapy, like CRRT, with mixed duration. Means like you don't run necessarily the CRRT for 24 hours. You can run it maybe for 8 hours and at least allocate 2 patients for one single machine in a 24-hour cycle. Also, you can continue to do HD for patients that can tolerate. If this is not enough, we can use the machines that we use for HD also to provide a SLED or intermittent or persistent intermittent renal replacement therapy. With the problem with doing the PERT or SLED is like the HD machines need to be operated by the dialysis nurses. And of course, this is an extra workforce that needs to mobilize to the ICU to monitor, not to monitor necessarily, but to connect the patient to the machine, to disconnect, and then also to troubleshoot any issues during the treatment that can be monitored with the ICU nurse. And we have been working on starting an acute PD program as well for patients that can have a bedside procedure of PD catheter insertion, or for patients that are not COVID-19 that needs to be started on renal replacement therapy chronically for end-stage kidney disease management. So the recommendation, go ahead.
This work well if the patient is on mechanical ventilation?
Yes, you can. The protocol we have for insertion of a peritoneal dialysis catheter is for patients that are sedated on mechanical ventilation and that they do not have any intra-abdominal active pathology that the surgeons can easily at the bedside insert the catheter.
And it doesn't interfere with ventilator functions in patients who are, yes, okay.
Yeah, so that's a good question. It should not interfere, but of course, if you have patients with high PEEP, especially in some of these COVID-19 patients with severe ARDS that are in high PEEP, you may have a little bit of problem with the if you require large volumes. But for the protocol we created, taking into account that these patients may be on mechanical ventilation with high PEEP, and that there may be risk of catheter leak more than patients that they insert the catheter in the OR. We recommend only 1 liter exchanges of fluid. So the patient will not be that full and will use most of the time cyclers. So that will minimize the risk of any interference with mechanical ventilation.
Thank you very much, Professor Javier. It is a very nice presentation and stimulative. And as you know, the time is very restricting us. Thank you very much. And I think we can proceed to the next talk. Professor Tyler Diasti is with us.
Yes, Dr. Hussein.
Dr. Tyler Diasti.
دكتور حسين مع حضرتك.
So أقدم حضرتك يا باشا. So it is my pleasure and honor to introduce Professor Tariq Diasti. He is a well-known figure in Egypt, in the Arab world, in Africa, and in Europe, and all over the world. And I am very proud. He is professor of radiology, and I am a nephrologist. But I learn a lot from his attitude. He is a role model, and we are proud that we work with Professor Tariq Diasti at Urology and Nephrology Center for the last 27 years. We learned a lot from you, Professor Tariq, and we are honored that you have the State Award of Appreciation and the appreciation of our President Sisi last year. So you are a role model, and I think COVID-19 also affects the radiology practice, and we are afraid and to how to take the equipments and protect our colleagues in the radiology department. And I think your talk is very interesting, and we are waiting your data. Professor Diasti.
Dr. Tariq, can I say something very quick?
Aisha?
Please, Amr.
Professor Hussein and Professor Amr, may I ask you just to give this certificate, appreciation certificate for Professor Javier Naira for his elegant contribution to طنطا conference, and we are very glad actually to hear him.
It's very kind from you, Professor Kamal. Thank you very much for this.
Thank you
very
so much.
Nice.
Thank you so much. Thank you, Professor Naira.
Dr. Amr.
Professor
So,
Amr.
yeah, I know, Dr. Tariq, I cannot just let this opportunity go without saying something about Dr. Tariq, because I know him since I joined Mansoura Urology Nephrology Center in 1994, and he is a very spectacular physician. He is very influential, and his knowledge, and as Dr. Hussein said, he teaches us a lot in the past, and his knowledge usually touches our brain. But most importantly, his humility, his modesty, and his humbleness touches our heart. I'm really happy to see and hear from our professor, Dr. Tariq Diasti.
Thank you so much, Professor Hussein and Professor Amr, for this very kind introduction. I would like to thank all of the leaders in طنطا University and all organizers of such a great virtual meeting on response to COVID-19 epidemic. So
Thank you, Professor. Contribution as usual.
Kamal. Kamal.
Dr. Hussein.
There is a problem in the sound. مش عارف.
Professor Tariq is preparing his talks. That's it.
Okay.
It's okay now.
Yeah.
Dr. Tariq, اتفضل.
Okay. So, dear colleagues and dear participants, I would like to thank all the organizers, and I hope that you are currently safe and at this challenging time. This is my talk, and as you know, radiology services encountering the disease COVID-19 encountering the coronavirus COVID-19 pandemic will need to modify their daily operational. And radiologists worldwide have benefited from the considering volume of literature on the infection control, imaging appearances, and level of COVID-19 pneumonia that has emerged from high incidence practice. This is the outline of my talk. I will cover essentials for radiologists that all radiologists need to know, protocols for patient transfer to and scanning in radiology department. These protocols should be based on clear infection control guidelines, including droplet type of precautions. Then we have now better understanding of CT signs of COVID-19 pneumonia due to the hundreds of publications on these signs, and now we try to from those of other type of viral pneumonia. Then I will cover the COVID-19 imaging reporting and data system, which is called COVID RADS, as justification or stratification system for the risk of COVID infection. Then evaluating the course of the disease based on the positive correlation between imaging findings and the clinical picture in many published articles. And lastly, important notes that by these notes we can have such chest CT and CT scan of different patients with COVID-19 infection in appropriate and useful approach. So some points to radiologists. First, radiology policy goals are to reduce COVID-19 related morbidity and mortality through early appropriate treatment and prevention of disease dissemination. Then imaging is not routinely used to screen COVID-19 unless access to real-time PCR results for COVID is limited. Also, we have to postpone elective imaging because postponing this elective imaging will preserve resources and hospital beds while also limiting patient population exposure. Determining of time sensitivity of حسين، أنا عندي في مربع طالع في الكوسي مغطي نص السلايدز، فأنا مش شايف الجزء اللي على اليمين. هل ممكن
دكتور طارق؟
الجزء اللي حضرتك ظاهر فيه دلوقتي يا دكتور عمرو مغطي جزء كبير من السلايد عندي في
You can minimize it, I think.
بحيث أنا
We see you well. We don't have problem seeing the slides.
مش شايف الجزء اللي على الرايت هاند سايد.
دكتور طارق الشرايح باينه كويس جدا، فحضرتك ظبط الفيو عندك، يعني شوف الفيو اللي يناسبك. يعني
حرك الويندو،
ما هي دي ثابته، حاولت اغيرها، هي ثابته بالنسبه لي انا هنا مغطى. هل ممكن نشيل خالص الجزء اللي فيه بعض المشاركين من
عندك في زرار في النص من المايز وافتح السكرين واعمل، يعني حاول تلعب فيه بحيث انه يظبط لك الحاجه.
Anybody from the IT can you help? Anybody from IT help دكتور طارق؟
دكتور طارق حضرتك افتح البرزنتيشن واحنا شايفين مع حضرتك السكرين كويس جدا. يعني حضرتك
انا في جزء اللي حضرتك طالعه فيه الجزء البوكس ده مغطي على ربع الكلام اللي على الرايت هاند سايد.
هو حضرتك عملت لنا شيرنج، حضرتك ممكن تعمل مينيمايزيشن للويبكس خالص وحضرتك present from the slides.
اوكي. ستيل مغطيه برضو حضرتك.
استاذن حضرتك يا دكتور، حضرتك الصوره دي اقف عليها.
موافق عليها.
اقف عليها. تمام. في على شمالها سهم لتحت، لما وقفت عليها بالماوس في على شمالها سهم لاسفل. تمام.
تمام. كده تمام.
تمام، شكرا. اتفضل.
Also, radiology departments must prepare for patient surgeries through streamlined approaches to imaging that will limit exposure to health patients. Also, the decision to image patients who are COVID-19 positive or suspected is based on how the imaging will impact patient care. Of CT imaging for patient with suspected pulmonary embolism. Here on the pulmonary window, we can see here the defect of the pulmonary embolism in axial and coronal images. And also when we do contrast enhanced study, usually excluding complication, we have to have the pre-contrast series, because if we don't have the pre-contrast, the injection of contrast material may mask the appearance or change the appearance of ground glass opacities, which is a common finding on COVID teeth. So what are the indications for imaging? For the imaging of patient with potential confirmed COVID-19 demonstrates a degree of variation globally. This the difference in local resources and guidelines used in this area or region, and also to the socio-culture approach to to imaging in this country. The use of CT as a primary screening tool is discouraged because there are studies that show that they suffer from selection bias, with a recent meta-analysis reporting a pooled sensitivity of 94% and specificity of 37%. In a resource-constrained environment like here, imaging is indicated for patients with suspected COVID-19 who present with moderate to severe clinical pre-test probability of disease. So patients requiring general radiography should receive it portably or in a dedicated unit to reduce or to limit transportation and also to reduce viral transmission. This is an example of portable X-ray in intensive care unit at admission 4 hours, 24 hours, and 48 hours with worsening of the patient condition. There is some case studies reported that chest radiography can be done in the intensive care through a glass. Here, the technician have the portable X-ray outside the isolation room, and the tube can be peered through a glass window in the room, and we have an acceptable resolution of this chest, which is in the upright position. Characteristic features of CT from these multiple studies here. The common feature is ground glass opacity, which here with multiple peripheral and affect more the inferior lobe and on the right lung more than the left lung. Ground glass opacity means opacity you can see the lung markings, so the bronchovascular marking are seen through this opacity. Also, there is what is called crazy paving, sometimes due to thickening of the interlobular and intralobular lines in combination with the ground glass opacity, giving what is called crazy paving stone feature. Vascular dilatation, a typical finding in the area of the ground glass opacity is widening of the vessels. And here also traction bronchiectasis, we can see through the ground glass opacity dilated bronchi with traction, so traction bronchiectasis. Also subpleural architecture distortion with formation of subpleural bands are the last characteristic finding. Here we can see the typical finding, and very atypical finding of COVID-19. How to differentiate CT findings of COVID-19 from other viral pneumonia? There are some points. First, the peripheral distribution only without central distribution is more with COVID-19. Predominant reticular and ground glass opacities are more common with COVID-19 than other viral pneumonias. Vascular thickening is significantly more common in COVID-19. Pleural effusion, lymphadenopathy, pulmonary nodules are not characteristic to and less common than viral pneumonia, while cavitation and calcification are nearly excluded in COVID-19 pneumonia. So what about this COVID-19 imaging reporting and data system, abbreviated as COVID-RADS? This is has been published on last March. The COVID-RADS classification is a standardized reporting system for patients with suspected COVID-19 infection, developed for moderate to high prevalence setting. It is a proposed classification system for radiologists in the Netherlands and still work in progress. Based on CT finding, the level of suspicion of COVID-19 infection is graded from low or COVID-1 to very high or COVID-5, and the severity and the stage of the disease is determined with remarks on comorbidity and differential diagnosis. The proposed COVID-RADS would improve the communication of findings to other healthcare providers, thus facilitating the diagnosis and management. This is summarize the level of suspicion of COVID-19 infection according to the CORADs. CORAD 1, no suspicion, very low. CORAD 2, 3, high suspicion, 4, very high, 5, and 6 positive PCR, any CT finding. This is an example of some CORADs. CORAD 1 with COVID infection is highly unlikely. The CT image is of patient with complaint for 5 days. There is no abnormalities and the PCR was negative. CORADs 2 level of suspicion is low. The finding consistent with other infection like typical bronchiolitis, so no typical signs of COVID-19. The CT image here show a bronchiectasis and the bronchial wall thickening with what is called the tree in bud appearance, which with no evidence of ground glass appearance. Indeterminate COVID, the CT abnormalities indicating infection like lobar pneumonia, but unusual whether COVID-19 is involved. This is 2 patients. This one has had symptoms 7 days prior to CT. There is multifocal with surrounding ground glass appearance. PCR is negative. The other patient showed bilateral central consolidations with COVID-19 pre-test negative, PCR negative, and influenza A positive. This is the suspicion. The suspicion here is high in COVID-4. There is 2 patients. Number 1 is unilateral ground glass multifocal consolidation without any typical finding. And number 3, there is COVID-19 in underlying pulmonary emphysema. Here, the high suspicion of COVID infection, multifocal ground glass opacity and consolidation bilaterally. And here there is bilateral ground glass opacities and consolidation with basal preference and vascular thickening like here. So even PCR here is negative. It is highly suspicious of COVID-19 infection. CoRADS 6, it is with PCR positive, and also there is atypical features on CT, on coronal and sagittal view. So what's the limitation of COVID rates? The inter-observer variation of CoRADS 2 to 4 is still high. The interpretation of CT findings has to be combined with the clinical symptoms and the duration of the symptoms, as a CT can be negative in the first few days of mild infection. So based on the positive correlation between clinical setting or the clinical picture of the patient and the appearance on CT, the imaging can be used to evaluate the course of the disease. So we can classify the appearance into mild type, ranging from obvious abnormal change, from no abnormal change in both lungs to just enlargement of the lung hilum and thickening of the lung texture. Severe type, like here, we can see the CT features with ground glass opacities and pulmonary consolidation, enlargement of bronchi and vessels. The ground glass opacities were irregular and with distribution in fan shape and with ill-defined borders. Here's the critical type. The axial CT image show symptoms, show extensive ground glass opacities, confluent lesions in multiple lobes, giving what is called the white lung. So it is usually with the critical patient. So I will finish with this important notes. In clinically suspected patients, the negative imaging should be repeated. The suggestive imaging with negative swab may not exclude the diagnosis. Radiology department should rapidly deploy technology solutions that allow radiologists to contribute remotely, including examination, protocoling, interpretation, and multidisciplinary case discussion. So much for your attention.
Thank you very much, Professor Epithelium, for this review about the role of radiologists in combating COVID-19. I think the concept of using CT scan is evolving. In the starting point of the disease, we encourage the patient by CT, and nowadays we are discouraging. We follow the patient clinically, chest X-ray, and the oximetry to reduce the rate of contamination within the radiology department. I think because of the time restriction, we should say thank you very much, Professor Tariq, and we will move to the next speaker. Thank you, Dr. Tariq.
Professor Shaisha, please. This is an appreciation certificate for Professor Tariq Al-Dasti for his elegant contribution to our virtual meeting. Thank you, Professor Tariq, for your very nice talk. And we still, I think,
Thank you, Professor Kamal.
Dr. Hussein, we still stick with the CT until today. I think is a gold standard, I guess, for now to diagnose the air chest manifestation for COVID-19.
So let us to hear from Professor Ayman Abdel-Zahir, the professor of chest medicine, about the respiratory manifestation of this disease. And from my point of view, Dr. Kamal, I think it is wise to restrict the use of CT scan, because at the end of the day, all CT scan findings are not so specific to COVID-19. And it increases the prevalence of COVID exposure to COVID-19 in radiology department. So we should limit CT scan as we can. Now it is my pleasure to introduce Professor Ayman Abdel-Zahir, Professor of Chest Diseases at طنطا University, to speak about respiratory manifestation, coronavirus, COVID-19, the invisible enemy. Professor Ayman.
Thanks, Mr. Chairman. في البداية السلام عليكم وعلى جميع المتواجدين أساتذتي وزملائي الأعزاء. Dear friends and professor, hello everybody. Thanks, Mr. Chairman. I am pleased to share in this first international virtual conference in my university. I will speak on respiratory manifestation of coronavirus COVID-19, the invisible enemy. For the sake of time, I will stress on some slides. The agenda of my talk will include background, international and national situation, characteristics of COVID-19, pathogenesis, clinical presentation, diagnosis, and management. At first, human coronavirus was first identified in mid-60s. They are zoonotic, which means they can be transmitted from animal to human and can cause illness ranging from common cold to severe illness. The subfamily of coronavirus, coronavirus, classified into 4 generation group: alpha, beta, delta, and gamma. They are named for their crown-like spikes on their surface. They are large viruses ranging size 60 to 140 nanometer. The most common human coronavirus which lead to outbreaks, SARS and MERS, and the new one is SARS-CoV-2 or novel coronavirus. The R0 or reproductive rate ranging from 2.2 to 6.5. This diagram illustrates the outbreak which occurred first at SARS in 2002. The main reservoir with snake and bats and wild animal. It's occurred also in China, while MERS occurred in Gulf area and Saudi Arabia and in 2012, and the reservoir was camel. Now we have SARS-CoV-19. The intermediate host is pangolin. Global history of COVID-19, first case was discovered in Wuhan city, China in December 2019. Large outbreak occurred in Italy in February 2020. First case in UK and presented in February 2020. And then WHO declared pandemic in March 2020. This is a famous report of WHO about the situation. Also, the John Hopkins tell us the new cases and mortality rate same. In our locality, we have this figure, 25th of May, 17,967. Now, yesterday, it became 18,756. In our Gharbiya locality, we have 8% of this total new cases. Transmission of COVID-19, at first it was known when dealing with or eating of uncooked seafood. Later, droplet infection became the primary mode of transmission. Also, transmission can occur in healthcare workers through aerosol generating procedure like endotracheal intubation, nebulizer, manual ventilation. Also, touching infected area, surface or object, and then touching their own mouth, nose, eyes. A case record in China and London occurred in baby just 30 hours after birth. The incubation period range of between 2 and 14 days. The median incubation period is 5 days, as said by WHO and CDC. Pathogenesis of COVID-19, the route of entry, as all of know, is ACE receptor. The ACE receptor is not sensitive to ACE inhibitor drugs. The effect of ACE or RB is unclear. Now it's not recommended to change medication. ACE present in intestinal epithelial cells, kidney, and type 2 pneumocytes. When COVID enter the body, it make a state of viremia, attacking the endothelium, and the body react with acute phase response in the early stage. Later, after 10 to 15 days, there is a cytokine storm with severe endothelial dysfunction and progressive microvascular thrombosis and multi-organ failure and later mortality. Here's the diagram of SARS-CoV, where the spikes can fuse and enter the cell through ACE receptor, where it attacks the lysosome, where it replicates till form a protein, then exocytosis. We have two immune phases, early stage and severe stage. The response to infection depends on health status and HALA type. So if the immune status is well, the infection can goes on without any mortality. At the first early stage, we can boost the immune response by giving interferon, maybe anti-sera. Later, in severe cases, there is cytokine CRPS, cytokine release syndrome. At this stage, inhibition of hyaluronate synthetase or elimination of hyaluronine, giving activated the mesenchymal stem cells can be used to block inflammation and promote tissue rehabilitation or repair. Also, vitamin B3 can be help immune system. The clinical presentation goes in through stages. First stage, early infection, which presented by mild constitutional symptoms, a fever. The most remarkable signs is lymphopenia. Later, we enter to pulmonary phase, where there's dyspnea, shortness of breath, and hypoxemia. PF less than 300 millimeter mercury, associated with abnormal chest imaging and CT. Later, in severe cases, we go to severe inflammation and cytokine storm, and there is the ARDS and the multi-organ failure, and the marker of inflammation will be high. The course goes early. The early stage occurs in 5 days. Later, after 10 days, the patient become worsened and enter to the severe inflammatory, where immune suppression is recommended. The main clinical presentation or symptoms, fever and cough, represent about 90% in case of fever and cough, 70%. Less common symptoms is rhinorrhea. Manifestation of severe pneumonia, which occur in 14% of patients. There is fever plus high respiratory rate above 30 cycles per minute, BF ratio less than 30, and the saturation less 90-30 on room air. Most of the cases of COVID-19, about 80%, will be mild to moderate. The critical case represent only 5%. The overall case fatality rate is between 2.3 to 6%. Also, in severe cases, we have sepsis or septic shock. We can identify sepsis by SOFA score. sequential organ failure assessment, which include hypoxemia, thrombocytopenia, hypotension, altered mental status, reduced urine output, or increased creatinine. If so far more than 2, there is a sepsis. If the condition worsen, there is a septic shock. There is what I mean by septic shock: persistence of hypotension and spike vasopressor and increase of lactate level. Here, our Egyptian guideline classifies the case to mild, moderate, severe, and critical case. A critical case further subdivided into early, middle, late stage according to PF ratio, where PF ratio 200 to 300 is early, middle stage 100 to 200, less 100 is severe form or late stage, and the mortality risk is significantly increased. What about the risk factor and prognostic determinant? The epidemiological study shows that older age, male sex, obesity, medical comorbidity like diabetes, hypertension, chronic pulmonary disease, asthma, COPD, bronchogenic carcinoma, cystic fibrosis, interstitial lung disease, and chronic renal diseases will have bad prognosis. How can we predict this bad prognosis? By these items. When I have a high temperature, higher associated with higher fertility, lymphopenia, absolute lymphopenia less than 1,000 to 2,000, NL ratio more than 3.17 associated with higher mortality, LDH more than 245, increased cardiac troponin more than 28 nanogram per meter, prothrombin time prolonged, serum ferritin more than 300 gram per liter, and also increased D-dimer 1,000 to 3,000, and CRP more than 100 milligram per deciliter.
ايمن باشا.
ايوه باشا تحت امرك.
التايم يعني 2 minutes.
التايم بتاعي يا باشا انا كان من ساعه.
ماشي
بس انا زي تحت امرك حاضر.
بس انتوا اهل البيت، انتوا اهل البيت.
ماشي يا باشا حاضر.
يلا.
طب الديفنس طبعا الدايجنوز طبعا هو البي سي ار، طبعا سامبل عن طريق النيزوفرنجال سواب. السبيوتم اندكشن نوت ريكومندد. البرونكوسكوبي ليميتد تو intubated patient because potential to transmit infection. All respiratory specimen should be in negative pressure room. Additional samples through blood, stool, and urine can be. ذا راديولوجي طبعا الدكتور طارق غطاه. طبعا البلين اكس راي السنسيتيفيتي بتاعته قليله 60%. طبعا ما انساش ان انا افرق ما بين الكارديوجينيك والنون كارديوجينيك بالمونري اديما. طبعا الرول اوف سي تي دكتور طارق غطاه. طبعا هو طبعا بيعمل تراياج اوف بيشنت، بريدكشن الورسننج والكومبليكيشن، ويتوقع الامبروفمنت والالترناتيف دايجنوزس، ويساعد السولفنج. طبعا دي الحاجات دي غطاها الدكتور طارق عشان برضه فاهم. ده البريتش جايد لاين عشان ما اطولش عليكم. طبعا السي تي بيمر بمراحل اكوردنج تو بان اتال. ايرلي ستيج ده بتحصل في اول 4 ايام، الادفانسد ستيج من 5 ل 8 ايام. الايرلي ستيج بتبقى نورمال او جراوند جلاس ابييرنس، الادفانسد بتبقى انكريز في الجراوند جلاس، ومع الانكريز الكريزي بيرنج ليتر الكونسوليديشن، بعد كده الديسبشن او الابزوربشن ستيج في اخر حاجه الجراديوال سوليوشن يبتدي يظهر فايبرس ستريس. طبعا دي الايجيبشن جايد لاين ذا سيم از جلوبال جايد لاين او WHO. طبعا الامبورتنت نيجاتيف طبعا الدكتور طارق غطاها. طبعا لو وجود برو ريفيوجن، نيموثوركس، ليمفادينوباثي، لانج، نديول، سبيسيفيك زونال بريدومينانس، كل الحاجات دي بتنفذ ان هو كوفيد 19. طبعا لما الحاله تبقى سيفير لازم اعمل الحاجات دي، لازم اطمن على البالس اوكسيمتري، الاي بي جي، السي بي سي، الليفر انزيم، الكواجليشن بروفايل، انفلاماتري ماركر، كارديك تبنين، ال دي اتش، والسيرم كاينيز. من الحاجات الجديده اللي هو الكول سكور. كان زمان احنا بنعتمد على الكيرب سكور عشان نشوف النيمونيا سيفيريتي اندكس. في سكور جديد اللي هو الكول سكور، وده بروجنوستيك عشان يقول لي الحاله دي سيفير كوفيد ولا لا. وجود الكوموربيديتي او ابسنس، الايدج اقل من 60 او اكثر من 60، الليمفوسايت اكتر من 1000 واقل من 1000، والال دي اتش اقل من 250 واكتر من 500. لو هذه مجموعه هذا السكور اكتر من 6 يبقى الحاله 50% من الحالات هتبقى سيفير، اقل من 6 يبقى ليس سيفير. طبعا ده بالنسبه للجايد لاين الكيس ديفينيشن، مش عاوز اخش فيها بقى عشان هي ما تطولش عليكم. طبعا الجنرال مانجمنت هو مالوش سبيسيفيك، هو طبعا سبورتيف اند سيمتوماتيك تريتمنت. طبعا من الحاجات المهمه ان انا اهتم بالنيوتريشن والفيتامينز بسايدز الاكسجين الانتيبيوتكس. طبعا many of drugs antiviral tried. عندنا الانترفيرون الفا، اللوبينافير، ريتينوفير، ريميديسفير. من الحاجات اللي عليها كلام الكلوروكين وهيدروكسيكلوروكين اخده ايرلي عشان اخد ريزلت كويسه. الفافيبرافير، اليوز ايرلي بانتي كواجلانت، الانتي انفلاماتوري توسيليزماب، الكورتيكوستيرويد. في كلام اليومين دولت على الكاينيز انهبيتور عشان هو بيعمل بلوكينج للسيجنال باس واي. طبعا في حالات السيفير كيس النون انفيسيف فنتيليشن والميكانيكال فنتيليشن. طبعا البروتوكول بتاع الميكانيكال فنتيليشن اللي هو بروتكتيف لانج استراتيجي، اللي هو لو تايدال فوليوم، هاي الريسبيراتوري يبقى اقل من 30 مع لو انسبيراتوري بريشر، والبيب بتاعي بيبقى اكتر من 10. طبعا البرون بوزيشن بيساعد الحالات دهيت. لو الحاله تطورت ودخلنا في المالتي اورجان فيلير طبعا الايكمو عشان يعالج الريفراكتوري هايبوكسيميا. ده التشاينيز تريتمنت. اخر حاجه الدبليو اتش او ريكومنديشن، طبعا هي اهم حاجه الوشان، ويعني عشان ما اطولش عليكم البروفايدنج اوف بي بي اي. وان سلايد في سياتل انتنسيف جايد للكوفيد 19 مجمعه كل الكلام اللي انا قلته ده. Lastly, WHO strategy aims to end the COVID-19 pandemic and assist. Their main objective is to slow and stop transmission, provide optimized care for all patients, and minimize impact of the epidemic on health system, social services, and economic activity. The clinical manifestation of COVID-19 pass into 3 stages. Our goal is to catch patient in early stage before cytokine releasing storm or cytokine storm. Thank you.
Thank you very much, Professor Ayman Abdelzahir. Excellent presentation and cover the respiratory system. Very nice. And thank you very much.
May I ask Professor Ayman Abdelzahir just to give a very brief recommendation for COVID-19 nowadays, I mean today. So if the patient has mild symptoms, if the patient has severe symptoms, if the patient had, what is the indication for ventilation? Just very briefly, Professor Ayman, because this is what we want to learn today from this kind of webinar.
اهم حاجه دكتور كمال في موضوع امتى هدخله العنايه وما ادخلوش العنايه عن طريق الاكسجين ساتوريشن مع وجود الديسنيا. طبعا الكورليشن ما بين الكلينيكال اند ريلوجيكال اند لاب مع وجود البروجنوستيك ماركر. طبعا هي دي الحاجات اللي بتساعدني. لو لقيت طبعا الدي دايمر هايلي اليفيتد، الانزيمز بتاع الليفر عاليه، ال دي اتش عاليه، مع سيفير ديسنيا، مع سيفير تاكيبنيا، الاكسجين ساتوريشن بتاعي اقل من 93 مع سيفير ديسنيا، والاي بي جي في ريفراكتوري هايبوكسيميا، ده الحالات دي لازم must be admitted to the intensive care.
Dr. Ayman, regarding the early ventilation, do you recommend early or to be more conservative in starting ventilation?
في بدايه الجائحه هم كانوا بيقولوا early ventilation. مع الاستاديز ابتدت لقوا الفنتليتور لوحده هو بيعمل مور انفلاميشن، فاجلوا موضوع الانتيوبيشن للليت ستيج.
Thank you very much.
Professor Hussein and Professor Ayman, Professor Amr. This is appreciation certificate for Professor Ayman Abdelzahir for his marvelous contribution to our virtual conference. And thank you very much, Dr. Ayman, for being with us.